Hi, I'm Dr. Nicole Lurie. I'm Strategic Advisor at the Coalition for Epidemic Preparedness Innovations, or CEPI, and prior to that, I served for 8 years as Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services. Dr. Press asked if I would share with you some of my perspectives about the early aspects of the U.S. COVID response. So just as I begin, want to say that the response was pretty multifactorial, and we could see it happening at a number of different levels, at a global level, at a U.S. government level, at a state and local level, and an individual facility level. And I'm looking forward to the session because we're going to hear about this from multiple different perspectives. So from my own perspective, first sitting at CEPI, where I also am the response lead, I first started hearing about rumors of an unexplained outbreak of pneumonia in China in late December 2019. And by the week of Christmas or so, this was suggested to be a novel coronavirus. By December 31st, as we all know, China notified the WHO about this cluster, and ultimately the sequence was posted on January 11th. So from my position at CEPI, having learned from the US government, my perspective was the role was really to think about first how to protect the public from harms and to prepare for the worst, to scale back if the worst doesn't matter. So for us at CEPI, it meant thinking about how to start vaccine development. From my US government perspective, it meant taking a whole series of actions which we can talk about now. So from my own perspective at that time, there were a number of missed opportunities for early action. If as a government official, you're going to prepare for the worst, the first thing that you really want to do is convene a whole of government effort, examine the potential scenarios, looking at how this could all unfold and make a plan for each. In my own mind, that should have happened late December, let's say Christmas week and probably the week after into early January. Make a plan for each one of those scenarios or how they might unfold and get more information. I think we all appreciate now that that really didn't happen. Next, communicating from the top in a clear, forthright, and consistent way about the severity of the threat. And ultimately, as we have seen, the need for an all hands on deck response. Initially, there was no communication, let alone communication from the top. And then as communication started, I think as we all know, the messages were mixed really for at least a year. Third, near and dear to all of our hearts as NAM and NAS members, developing and executing a real-time research agenda for dealing with the unknown. In every other crisis in which I have dealt, where there was a unique situation, we would pull together members of the Academy, ask them to convene a meeting and identify what a research agenda was. In the case of COVID, I think it would have really helped enumerate the priority research questions, particularly with regard to transmission and others, and to focus the whole research community, both inside and outside of government, in the private sector and academia, et cetera, on what those priority issues were. Now, I'll say that the research community did pretty well on its own, and what's been accomplished from a research perspective is quite incredible. By the same token, there were really important missed opportunities early on to get this focus where it needed to be. Whenever you're confronted with a new disease or a new situation like this, you really need to strengthen surveillance and strengthen testing. And we know that this is another area where there was a lot of struggle. Certainly, we know that the US CDC's efforts to develop a diagnostic test failed early. And while there were other diagnostic tests in use around the world and other PCR primers, they were not used here in the United States. But beyond that, given the very rapid rate of spread of this outside of China and to other places, and we'll hear about its spread in Washington state, it was clear from the get-go that large numbers of diagnostic tests were going to be needed, and diagnostic tests for a number of different purposes. It would have been really appropriate to reach out to private sector and academic labs and test developers, ask them to get going with the development of diagnostic tests, offer coordination and collaboration with FDA about validating those tests, and ultimately providing emergency use authorization for those tests. That didn't happen either, despite the fact that the US government, including BARDA, had all the authorities to go ahead and develop diagnostics. And instead, what we saw were one, faulty tests, and two, lots of tests with different test characteristics, many of them not very good, but no process really for guaranteeing their quality through the emergency use authorization. And likewise, private and academic labs, which were in a position to test, could not get licensed or certified. And so we were relying on a faulty test and a not capable at the scale it was being asked to perform series of public health labs. Number 5, early on, it was clear that we had a large epidemic, if not pandemic, on our hand, and that we would be needing personal protective equipment, including masks and other things, from the Strategic National Stockpile. This happened during both H1N1 and during Ebola in the United States, where there was a run on these things. It would have been really appropriate to look at what was in the Strategic National Stockpile and what would be needed. And had one even done a cursory look, it would have been clear that there were nowhere near enough masks, for example, to take care of things in the early stages of this epidemic. And so what should we have done? First of all, we should have thought about crisis standards of care early on, particularly how to conserve the equipment we had. And secondly, again, that first week and latest, that second week in January, the US government should have executed contracts, in my opinion, for surge manufacturing of masks and other personal protective equipment so that we would have it in hand as quickly as possible. Again, that didn't happen either. Number 6, as soon as we heard that there was a serious outbreak in China, it should have been very, very clear that because so much of our supply chain and so much of our health and medical supply chain comes from China, that regardless of what was going to happen, the supply chain was going to be compromised. We have a lot of supply chain vulnerabilities from the get-go. As we know, 80 to 90% of the API for critical drugs in this country comes from places like China and India. It's offshore, so any disruption in the supply chain is likely to cause trouble. We also knew from lots of pandemic planning and frankly from paying attention to the newspaper that all kinds of other equipment, whether it's PPE, whether it's laboratory equipment, whether it's the Q-tips that you might need or the swabs that you might need to swab somebody for a diagnostic test, whether it's pipette tips or the testing wells for ELISA, they also largely come from overseas and largely China. And so we should have had a really good look at the supply chain vulnerabilities and scaled up US production where it was needed, early rather than late. Number 7, preparing the healthcare system. We lost a good month, probably more, by not alerting the healthcare system early and having it prepare in terms of staffing, equipment and supplies, policies and procedures, and most important, community-wide planning through the healthcare coalitions that were in place for how communities were going to deal with an incredible surge in patients, share equipment, supplies, staff, other things. This isn't an isolated hospital event as we know, but it's an entire community or a higher national event. And preparing the healthcare system and giving them much more time to be ready and to provide clear guidance about the things they needed to do, again, would have been in order. For the most part, they were instead left on their own. Number 8, start countermeasure development early, as soon as this threat was detected. And by countermeasures, I mean diagnostics, therapeutics, and vaccines. As I said, from my vantage point at CEPI, we decided to start early. And thinking this was going to be a novel coronavirus, we actually called our vaccine developers prior to the time that the sequence was posted and said to them, if this really turns out to be a novel coronavirus, would you please pivot from what you are doing now to working on this new virus? We'll work out the financial arrangements with you over the next couple of weeks, but this is going to be urgent. Indeed, it was. It's terrific that NIAID, through all its work on mRNA vaccines, had gone ahead and downloaded the sequence and really accelerated work on what became the Moderna mRNA vaccine. They started this at a fairly routine level in early January, and it wasn't until large-scale funding in mid-March became available that the US government went all out on vaccines. But even before you start making vaccines, you desperately need diagnostics. And again, the work on diagnostics and ultimately therapeutics was very, very slow to start, largely because number one, BARDA didn't have an emerging infectious disease fund. And number two, they were hamstrung by an administration in being able to spend or reprogram money for this purpose. Next, coordinating and providing guidance for states. I think we all know now that states were left on their own, as were local governments and healthcare settings. And while there are some incredible governors from both parties and many terrific state public health leads, they were all left on their own. And so what you saw is everybody trying to do the best job they could under the circumstances, but different states and different healthcare settings doing really, really different things. Now, some of that might have been situationally appropriate, but other parts of it, for example, needed to be better coordinated. And this popcorn-like approach of different things all over the country really confused the public and made things very hard to manage. And then finally, the 10th item is mobilizing and coordinating the private sector. Lots and lots of missed opportunities when private sector entities offered to step up and help in different ways. None of that really happened until very late. And finally, as an overarching issue, all of this needed to be done through a lens of equity from the beginning. Why do I say that? Because in every single crisis and disaster, who is it that suffers most? It's low-income people, it's people of color, it's people with less education, it's often people who don't have English as a first language, et cetera. And so looking at who those vulnerable populations were and how they were going to fare and how to reach them from the beginning would have been very much in order. So I think I could go on, but I'm going to stop here, particularly because in contrast to this picture of what didn't happen in the federal government, there was just a lot of early action that happened at a state and local level, and you'll have a chance to hear about that now.
Hi, I'm Mayor Jenny Durkan, and I'm going to talk a little bit about what happens when public health and a global pandemic hit public policy. And what does that interplay between elected officials, public health officials, and the ground truth look like? The city of Seattle was one of the first cities that experienced hospitalization and death in the COVID experience. We saw that we were the epicenter of the first confirmed cases and the first deaths attributed to COVID-19 in the US. It required us to take steps we had never done before as a city or in working with public health. We, unfortunately, had no national playbook. We couldn't afford to wait for leadership from the White House because it wasn't coming. The CDC, which usually plays such a central role, wasn't playing the role that we needed them to play for the various reasons that you're going to hear about in these panels. We knew in Seattle that if we were going to make it, we needed to follow the science and the data. Early on, if you remember back to the beginning, we were following the recommendations on the NPI. We were moving through all the recommendations and figuring out what to do and model it for the nation. But it was not easy. Early meetings with public health professionals and research scientists showed us a model of runaway growth. If we didn't act quickly, our healthcare system and our city and region and probably our state were going to be overwhelmed. And it was difficult because there was no testing. And without that testing, we didn't have hard data showing us how much was in the community, but we were fortunately to have great research scientists and data experts here who've done a lot of modeling and told us what was in our future. And we knew we had to act. Quick and decisive actions were critical to saving lives. The only way to stop this virus from transmitting was to break us apart. There was no cure, there was no vaccine. And at that time, the treatments were questionable. So we went and said, how do we make sure we slow down transmission? One of the first recommendations, move people apart from each other. So as an employer, the city, and working with our major companies, we decided to telework. We had limited gatherings. We closed schools and libraries and community centers. We had clear messaging at every level of government. We also got ready for the worst by setting up isolation and quarantine facilities and determining how we could continue to do our work for the public in the face of a pandemic. We also knew one thing: we had to listen to the experts. We had to speak as one, as the World Health Organization said. The public needed transparency to know what they were really facing, and they needed their leaders communicating the same message, the clear message on what we needed people to do and why we needed them to do it. In the city of Seattle, as mayor, I was really fortunate. I was able to gather experts, both international, national, and local experts, everything from former White House Ebola task force members to the Fred Hutch, to the University of Washington, to the Institute of Disease Modeling, and met with them on a weekly basis so I could see what was next, should we be preparing for. That was invaluable for me as a leader. Testing, testing, testing. We got in this mess because we did not see it's coming, because we didn't have adequate testing. With limited testing, Seattle Fire Department, we knew that we had to do it ourselves. So I had our Seattle Fire Department train and get certified as testers. I then worked with leaders from South Korea to getting the testing kits that we needed, and worked with the University of Washington to get the lab space we needed. We went into long-term care facilities, but also started to stand up other testing capability. We had to see where this disease was and how quickly it was spreading. In early March, the first potential cluster was at the long-term care facility. We knew that it came too much as a surprise, and we had to set up testing and contact tracing. So we worked with State Department of Health, the city, Public Health, King County, and the UW, so that we could get a really robust testing protocol in place. For long-term care facilities, the city went into one facility and tested every resident and every provider, because though the CDC at the time was saying test only the people that were showing symptoms, we knew that the disease spread before that happened. So by doing that, we became a model to show that you could test and isolate and quarantine those people who did have the virus but weren't yet showing symptoms. That was critical to slowing spread. Seattle also knew that we had to get our own PPE. It became kind of a Hunger Games. We're city against the city, state against state, but we worked quickly to get as much PPE as we needed, both for our first responders, but also for our healthcare facilities. You know, Seattle opened up free, low barrier walk-up or testing sites. We became a model, not just for King County, but for the state. At the high water mark, Seattle was doing almost 20% in Washington state, though we don't represent that much of the population. That was critical for us, knowing where the spread was, being able to isolate and quarantine people and slow the spread of the disease. Over 1 million residents in Seattle and workers tested using our fire department model. We decided that if the city was the master of our own fate, we could do the job well. So our fire department became the testers, and we set up the facilities. We provided our own PPE. We had all of the back office thing, and we used the University of Washington for lab work. 1 out of 3 residents used those sites. They became not just good for controlling the disease, they themselves built trust between the public, the leaders, and the scientists, which was critical for our response during the pandemic, to have that trust. We had to have a data-driven approach. Key measures on COVID's impact on our workforce, our customer service, our response times, operated by the city. As the transmission trends increased, we would operate and change how our facilities worked. All of this was data-driven, both on how we operated the sites, but also what were they telling us about the spread of the disease. Same thing with reopening. It has to be driven by data. So we worked with our outside experts, the Department of Health, King County Public Health, to really come up, what will those metrics be scientifically to tell us when we can start turning back the dial to open up. Transmission in cases, hospitalizations, deaths, all of those were key indicators to what was happening in our community. Also looking at the availability of testing and contact tracing and what the infection rate was. How many people were showing up in testing and what percentage of people being tested were showing positive for COVID-19. That would tell us a lot about how much of the disease had spread in the community, but maybe not yet been detected. We knew also that as we looked down to the next marker, that vaccinations were going to be the key to coming out of COVID-19. And built into that was also a real challenge we had, and that was to make sure that we could equitably distribute those vaccines. There is no question that throughout the pandemic, that COVID hit our communities of color harder, both economically and health-wise, than other communities. We knew we were going to have difficulty getting to the most vulnerable in our communities to make sure that they got vaccinated equitably. The city has shown us, our city has done a really good job on equity, that you can have equitable vaccination policies and practices without giving up speed. You have to have a multimodal approach, which we did with mobile community pop-up clinics, working with community-based organizations, our healthcare settings, pharmacies, and a mass site. About 55% of the people that the city of Seattle has been responsible for vaccinating identify as BIPOC. We are a city of almost 70% Caucasian people. This kind of intentional work with communities of color is so critical, both because that's where the disease burden was, but also because of the historical distrust of medicine. Our equity first approach started with our mobile clinics. We got into long-term care facilities and into our low-income housing and made sure we were getting to those places where populations disproportionately impacted by the disease, but farthest from healthcare justice, that we could reach them. Our partnerships with our outreach and community organizations were critical to this. It resulted in getting higher rates of BIPOC vaccinations. This chart shows you that in each of the components we did, whether it was our mobile vaccination sites, our community vaccination events where we would go into the Filipino Community Center or work with Black churches, things like that, working with community-based organizations, or our fixed sites in the places that we knew people had less access to vaccination, that by being intentional, we were able to make sure that we were equitable. 1 year later, Seattle has the lowest number of confirmed cases, hospitalizations, and deaths of any major US city. Consistently, with widespread testing, help us identify outbreaks early and enabled quick mitigation strategies. We could tell where the disease was spreading, where the outbreaks were, and what different strategies we need to do to roll that back. 1 year later, we know that if most of the nation had taken steps similar to Seattle, King County, and Washington State, that our nation would have had many, many fewer deaths. One of the lessons I hope we learn out of this is how do we have a national playbook where every state does not have to make it up, where healthcare workers, scientists, and public health are united together in forging those public policies, and the public knows what it needs to do, that it's based on science and not on politics. The lessons we've learned and to prepare for the next pandemic are quite a few. And I think we have to do it in a systematic way. There was the early things we saw where our national response and supply chain just weren't ready. We needed PPE, testing supplies. Now we need vaccines. We were worried about hospital beds and ventilators. We weren't ready as a country for a pandemic of this size. We have to be ready for the next one. State and local health jurisdictions have to have the funding, the infrastructure, the technology, and the data systems in place, because you don't know who's going to be first. It could happen in any part of our country and any part of the globe. We also have to have operational partners that can both have the fixed sites, but also have the agility to get to the places, like our fire department. First testing first responders, going to senior housing, going into low-income housing. Having that agility is critical to meeting this. I think we can take a lot of the lessons we learned here and start applying them globally as well, because we, the developed countries, have not done what we need to do to help the rest of the globe. With this, I know we're going to be talking a lot more throughout this production, but I'd say this was the test of our times. And we have made it through almost. There's still a long road ahead of us, but we also know that because of transportation realities and the way our globe works, this will not be the last pandemic. We owe it to ourselves and to future generations to take a hard look on not just what worked, but what didn't work, and how do we get that better. I'm really looking forward to the panel to learn from people, and so that we can say, from the test of our times, we learned the lessons we need to, and next time we'll do better. Thank you very much.
So COVID gave my field a name the world now recognizes. We are epidemic modelers. We use math, statistics, computing, engineering, physics to model the emergence, spread, and control of deadly pathogens like SARS-CoV-2. And although many of our models are grounded in math that dates back to the early 1900s, the 21st century marked a real phase change in the kinds of questions we ask, the technologies we build, and our impact on public health and policies around the globe. The NIGMS's Midas program was an incredible catalyst. Founded in 2003, it was the brainchild of a visionary program officer, Irene Ekstrand, and embraced by the then director, Jeremy Berg. Prior to Midas, epidemic modelers had a really tough time finding funding. At NSF, we were too focused on human health. At NIH, study sections found our science foreign and hard to evaluate. But Midas solved that problem for about 15 years until 2018. It provided a sensible review process and a budget allocation to support the growth of an important but fledgling field. And although Midas gave us our roots and our wings, there was a several-year period just prior to the COVID pandemic when the community struggled to find its footing and funding. And importantly, the strong bridges that Midas had built between the scientists and the policymakers began to erode. And those are relationships that would have been invaluable in the beginning of the pandemic. So my backstory, I'm not going to tell you the whole story, but I want to share just one anecdote from the last decade. In the aftermath of the 2009 H1N1 pandemic, I worked with Texas's state health department to conduct a sort of after-action report and identify critical moments in the H1N1 response where models could have really improved the decision process. And then we actually built such models to support pandemic planning going forward. For example, this is a video of an app we developed that simulates a wide range of pandemic scenarios. The user can specify how fast it spreads, how deadly it is in different age groups, and then implement all sorts of antiviral, vaccination, social distancing measures. But perhaps the most prescient feature of this app is that we embedded a surveillance system that allows the user to view the unfolding threat through the lens of the type of really noisy, biased, imperfect data that we've been struggling to interpret throughout this pandemic. This is the exact same model, but deployed on multi-panel displays in the visualization lab at the University of Texas to support group tabletop preparedness exercises. We also, during this period, built online calculators to help with ventilator stockpiling, pharmacy-based deployment of medical countermeasures, and geographic optimization of vaccines to address socioeconomic disparities. And all of this was circa early 2010s. But when our visionary collaborators at the health department moved on because of cutbacks or greener pastures, and when threats like Ebola and Zika demanded urgent attention, these tools, the lessons learned, the training, sort of was all shelved. Fast forward to 2019. A couple years ago, we embarked on a promising project with the CDC in parallel with 4 other leading modeling groups from around the world to essentially scale what we had built for Texas up to the national scale to support the design of multi-layered interventions to combat future pandemics. And our models were about 80% baked when COVID emerged. And the 5 modeling groups in our entire field, hundreds of epidemic modelers worldwide, pivoted immediately and ever since have been firing on all cylinders to support the pandemic response. And generally speaking, we model to achieve 3 types of goals: to understand the threat, to forecast the threat, and to mitigate the threat. And I'm going to provide examples of each of these based primarily on work done by our team at the University of Texas COVID-19 Modeling Consortium, which is a loosely organized group of dozens of researchers from multiple institutions that have banded together since March of last year. So by understand the threat, what I mean is building models for the purpose of deriving urgent insight into the natural history, transmission dynamics, risk factors, vaccine efficacy, variants, et cetera, and often from very sparse and uncertain data, which requires careful modeling of not only the epidemiology, but also the observational process itself. Where is the data coming from? And as just one example of this type of modeling, I'll share the first of many different analyses that this one we conducted immediately after news broke about a new virus in the food markets of Wuhan. Our goal was to estimate three things: the prevalence of the virus in Wuhan, how fast it was growing, and its imminent global expansion during the Lunar New Year holiday. We didn't trust the data coming out of China at the time, so we used the date and location of the first 19 cases that were reported outside of China, along with global air travel, to basically triangulate what was happening in Wuhan. We estimated about a 7-day doubling period, and that by the January 22nd lockdown of Wuhan, when China had reported 425 cases, there were probably closer to 12,000. Using cell phone mobility data from within China, we projected that there were already hundreds of outbreaks underway by the time of the lockdown. This was a very early indication that the virus might have the makings of a global pandemic, which was unfortunately borne out in the weeks that followed. I'm going to say just a very few words about forecasting, which is arguably the most sexy, or at least the most visible, of our activities. It attracts many different modelers, including my group. It gets a lot of public attention and new funding initiatives. So the first forecasting request that we received was from the White House Coronavirus Task Force, just after Ambassador Birx took the reins in February of 2020. And we, along with several other modeling groups, were asked to project how many people would die from COVID in 2020. We refused to submit a hard forecast, and we clearly communicated that it would depend on the policies that were enacted and how people behave. To illustrate, instead of a forecast, we offered a series of scenario projections or counterfactual analyses. If we did nothing to control the virus, we projected that there would be over 1 million deaths. If we maintained strict and cautionary behavior and measures, we could limit deaths to under 50,000. And if we do something in between, which was essentially the roller coaster that we all rode through 2020, we projected around 400,000 deaths. In fact, there were 344,000 reported, and a recent JAMA article by Wolf et al. Puts that number over 500,000. Since that initial request, we have joined dozens of other modeling groups in building models that can actually provide reliable short-term forecasts of hospitalizations and deaths. The CDC and Nick Reich at UMass Amherst have been curating these forecasts and ensembling them, which basically means averaging their predictions, and is what you see on the right side of these graphs. There are many different flavors of models. Ours from University of Texas are unique in integrating cell phone mobility data as a way to indirectly estimate changing behavior. Finally, modeling to mitigate the threat, and that means to design effective interventions and support clinicians, school administrators, public health professionals, policymakers, and other folks that are on the front lines making the hard decisions. So name an intervention: face masks, proactive testing, vaccination, school potting, and I can point you to at least 15 great modeling studies published since 2020, some of the best of which have appeared in PNAS. I'm going to focus my examples today on Austin, Texas, where I live, and have had the privilege of serving on an executive task force that has guided the city's COVID response from the very beginning. It includes our mayor, our public health authority, our county judge, the executive leadership of all area hospitals, our public health department, the major universities in the area, public K-12 school district. And we have met every single week since March of last year, and sometimes up to 4 times a week, depending on what's going on. So here's how COVID has played out in Austin, as seen through our daily estimates of the reproduction number. A value above 1 in this graph means that the epidemic was growing, and a value below 1 means that it was declining. On March 14th, just after the first confirmations in Austin, all of our schools closed. Shortly after that, the city asked us to project what might happen with or without a shelter-in-place order. This convinced the city to enact the shelter-in-place order. And when the mayor went out in press conferences announcing our March 24th stay home, work safe order, he used our graphs to help explain it to the public. A week later, the state forced the city to open up the construction industry. The city's second request to us was to forecast the consequences of that. So we projected at that time that there would be a 4 to 8-fold increase in the risk to the construction workforce of about 50,000 workers. And this is a subpopulation with overlapping health, occupational, socioeconomic risks. And despite forceful messaging about worksite safety, when we looked at the hospitalization data retrospectively from this time period, we found that indeed construction workers were about 5 times more likely to end up with severe hospitalized COVID than their counterparts in other industries. So moving forward in time, Austin was forced to open in May by the state, leading to an early summer surge, and then was only allowed to tighten restrictions after our hospitals felt the strain, which did have the desired impact of reducing transmission. The return to school in the fall, various activities, fatigue, Thanksgiving, Christmas, all paved the way to a much larger winter wave that nearly overwhelmed our hospitals and triggered a local stage 5 lockdown. More recently, our deep freeze, spring break, emerging variants, and the counterbalancing rollout of vaccines have kept Austin in kind of a limbo, with the reproduction number hovering right around 1. Between late April of last year and today, my research team has conducted almost weekly analyses to provide situational awareness and to guide decision-making. In my opinion, the most important modeling we did was right at the end of that first stay-home period in April of 2020. The city knew that Texas was going to force a hard reopening on May 1st, and they needed a path forward that would address the public health threat while mitigating socioeconomic harm and operating within political and legal constraints. Our discussions led us to the following framework for designing a policy. First, we articulated 2 very specific goals. We wanted to keep our hospitals under capacity, and we wanted to avoid stay-home orders and other socioeconomically restrictive measures if at all possible. Second, we formulated policy options as various combinations of non-pharmaceutical interventions from loose to strict. And finally, we formulated 2 questions that the models could help us answer. What data should the city track? And based on that data, when should they take action? In other words, when should they move those policy levers? So we first evaluated the data question, and we found that daily COVID hospital admissions were the best option, providing far more reliable real-time information than cases, than positivity, than total hospitalizations or deaths. And then we developed a stochastic optimization framework that allow us to determine threshold levels of those hospital admissions for tightening and loosening the measures. The model was grounded in COVID data from Austin. Austin's healthcare capacity was built into our calculations. And the analyses yielded thresholds that ensured that our hospitals would not be overrun while minimizing the expected duration of the restrictive measures. So, and these papers present the methodology. The resulting framework has guided policy in Austin since May of 2020, and it's shown in this public-facing dashboard that's maintained by the city. It tracks COVID hospital admissions and clearly shows the thresholds that we derive between the different alert stages. Austin effectively socialized this policy from the very beginning and has provided clear and consistent messaging with each change in alert stage, like moving from orange to red, through press conferences, social media, and the like. Behind the scenes, we have continually pressure tested the model and the policies. We've updated our assumptions based on changing hospital capacity on many different occasions and our changing understanding of the virus. And we've even provided sort of fail-safe recommendations if the policy fails for opening our convention center as an alternative care site. So there are a lot of color-coded policies that are guiding schools, cities, countries around the globe. And they seem to make intuitive sense, but they may not make quantitative sense. When we've taken a close look at some of them, like France's ICU-based criteria for locking down, we find that many are likely to trigger too late to prevent overwhelming hospital surges. And then they end up paying the price not only in terms of excess morbidity and mortality, but also by waiting too long to act, they're forced to maintain lockdowns for a longer period of time on the back end. Anecdotally, the Austin policy has done the job it was designed to do. We only went into a single stage 5 order on December 23rd, and that narrowly prevented our ICUs from hitting our local capacity of 200 beds, which is what it was designed to do. And among the 22 regions of Texas, our trauma service areas, ours was the very last to trigger the statewide orders restricting elective surgeries, and ours was the first to come out of those orders. So we are now helping the city to navigate variants, statewide lifting of the face mask orders, behavioral fatigue, et cetera, as COVID vaccines continue to roll out at a good clip. Like many cities, Austin has seen stark socioeconomic disparities and impact. This is a map coloring our 43 zip codes according to the CDC's Social Vulnerability Index. And our most high vulnerability purple zip codes are majority Latino in East Austin, and our lower vulnerability green zip codes are majority white in West Austin. These two maps are showing two different things by zip code. The middle one is showing our estimates for the cumulative infection rate through early April. And the rightmost map is showing our estimates for vaccine uptake, also as of the beginning of April. This is the fraction of the adult population that has received at least one dose. And you see that vulnerability is positively correlated with both high burden in the middle and low vaccine uptake on the right. This is the same three-way correlation, just shown in a single graph, with the estimated attack rate on the x-axis, vaccine coverage on the y-axis, and then social vulnerability indicated in color with the most vulnerable zip codes in yellow. So the city is now well aware of these the gaps in uptake and is making a concerted effort to close those gaps. But looking back, we've asked, what if we had prioritized vaccines geographically based on COVID burden from the very start of the vaccine rollout? On the left are hospitalization projections for West versus East Austin from the start of the vaccine rollout, according to our current rollout priorities, assuming a moderate level of transmission. And on the right, we went back and said, what if the vaccines had instead been allocated to East Austin proportional to the cumulative burden in East Austin versus West Austin? And we estimate that this strategy actually would have prevented a lot of hospitalizations in East Austin at no cost to West Austin. So in closing, Austin provides a decent model for coordinated, scientifically grounded decision-making. And in part, it's sort of due to a coincidence of our local leadership seeing eye to eye with each other and doing their best to make evidence-based decisions. They pushed hard on our for-profit healthcare systems to commit resources and present a unified front to the public, even when their interests were not fully in alignment. And we, the pro bono academic researchers, had prior experience working with policymakers, and we had access to other sources of support, including a donation from a local philanthropic organization. But this kind of coordination is rare, and Austin's task force didn't have full authority. Not only did the state overturn a number of our local measures, but the University of Texas, which had at least 30,000 of its 50,000 students back in the heart of Austin all year, made its COVID policies autonomously. So in closing, I'm just going to take a step further back and share a comment that I made in response to a New York Times reporter who asked what needs to be rethought in the future. And what I said was that we must overcome our collective failure of imagination. The COVID pandemic took us by surprise. We spent decades planning for a pandemic that would resemble the viruses we already knew. We didn't plan for face masks, mass testing, stay-home orders, politicized decision-making, or devastating racial disparities. And looking forward, we need to prepare for a much broader range of threats. So I'd like to acknowledge the dozens of researchers at the University of Texas COVID-19 Modeling Consortium and our funders, and the modeling community at large, which has stepped up mostly behind the scenes to help the world understand and combat this unprecedented challenge. And in doing so, they've paved the way for a new era of pandemic science that's going to help us to advance the detection, the forecasting, and the containment of future pandemic threats. Thank you. I look forward to the panel discussion.
I'd like to use my time today to talk about why I think improving public health data, analytics, and modeling is key to improving our public health preparedness, preventing and responding better to the next pandemic. A few things you should know. The first is that there are a few central challenges facing epidemiology. The first one of which is that outbreaks keep happening, whether SARS in 2003, H1N1 in 2009, more recently Ebola, Zika, COVID. Major outbreaks happen about every 2 years. They threaten human lives, human health, and they threaten the economy too through major disruption. And it's not just the outbreaks that make headlines that we worry about. In 2020, there were 74 disease outbreak news reports published by the World Health Organization. And the year before, in 2019, there was almost 120. In order to be listed in the disease outbreak news, The event has to have either major possible consequences or major recognized consequences. It's not just the outbreaks that hit the front page of the newspaper that we worry about. There's major threats happening all the time. And I think that goes under recognized when we try to consider the magnitude of the threat to public health. Not only are outbreaks frequent and severe, they're also very difficult to control. The COVID pandemic has been ongoing for 16 months, and we have quite a lot ahead of us. In 2014, there was a major outbreak of Ebola in West Africa that went on for 2 years. That outbreak infected nearly 30,000 people. And even now, there's a new Ebola outbreak in Guinea, the site of the first Ebola outbreak in 2014. There have also been several recent ones in the Democratic Republic of Congo that have been difficult to control. So these events happen frequently. They're serious, they cause extended disruption, and they're a major threat to our lives and our livelihood and our security. So what can we do about it? Medical countermeasures like vaccines and therapeutics, that's always top of mind when we think about countering outbreak threats. I think the development of vaccines is one of the greatest public health achievements of all time. It may even be one of humanity's greatest achievements, period. But that's not to say medical countermeasures can solve every problem, because they can't. The research and development needed to create those vaccines is slow, it's expensive, and even when we have them at hand, even when we have a vaccine that we know works, we keep finding new failure modes, finding ways that those vaccines can't deliver for us all that we hope or wish that we would, because there are other elements to vaccines and making them useful that are more difficult to control. In 2017, for example, there was a major outbreak of yellow fever. At the same time, there was a shortage of the yellow fever vaccine, and we had to rely on a number of emergency measures to get through that outbreak that included fractionated dosing of that vaccine. For COVID, we have developed a vaccine way faster than anyone would have thought possible even a few years ago, but it will probably be at least another year until the world is vaccinated. And so it's clear that vaccines are hard to produce, they're a wonderful innovation, but they cannot be the only thing that we rely upon. I want to spend a second dwelling on the example of the Ebola vaccine, again, an incredible innovation. Thanks to a long history of research and development for Ebola, though in retrospect, maybe not enough, there were already several candidate Ebola products in research and development phases when the outbreak hit. But even with that head start, even then, it was not until the outbreak was brought under control using traditional public health measures, to the point where it was difficult to find enough people to power the clinical trials, that the vaccine was ready to trial, ready to bring into clinical trials. And now here we are 5 years later, still facing outbreaks of Ebola and still struggling to control them. We have this new tool in our toolkit, which is amazing, but a recent Ebola outbreak in DRC took almost 2 years to come under control. And again, that's with the vaccine. All this is to say that medical countermeasures cannot be the only tool in our toolkit. We need to be thinking about what other capabilities we can develop to incorporate into our outbreak response. I think we need more innovation, and the field of epidemiology is built on developments in data and analytics, and I think that's where we need to be looking for the next innovation. There's an old story about the founding of epidemiology. I think every epidemiologist knows it, and the story goes that in the year 1854, there was a cholera outbreak in London, and it killed a lot of people. It was a devastating turn of events. And at the time, it was not realized that cholera is spread through contaminated water. It was thought to be caused by bad air. But this epidemiologist, or who would come to be an epidemiologist, no such thing existed at the time, but he had an inkling that it wasn't bad air, that something else was afoot. And so he went door to door, and he asked residents where they got their water. And he plotted those water sources against the residents who fell ill. And he noticed some clustering. He noticed that there was a particular well where a lot of people who had gotten cholera reported drawing their water. He had someone remove the pump handle, and the outbreak was stopped in its tracks. Now, probably that's more of an allegorical story than a real one. I can't swear to the details. But I think it does point to the deep roots of data and epidemiology, and I think that it lights the way forward for where we should be going as a field. This is where outbreak data and modeling comes in. There's so much that modeling can do to support public health response. I want to talk a little bit about the kinds of things that modeling can do and how it can be helpful. The first is forecasting the expected future number of cases. A similar analysis called nowcasting estimates the current number of cases that have not yet made it through the surveillance pipeline. These will seem familiar because they're very similar to another kind of forecasting that nearly everyone knows, and that's weather forecasting. Weather forecasts tell us what kind of weather to expect in the next few hours, days, even a week or two out. And we use that information to make decisions about whether to plan an outing to the park this weekend or whether to bring an umbrella. Interestingly, though, that personal use of weather forecasting is quite new. Originally, the enterprise of weather forecasting was motivated by commercial interests. Cargo ships wanted to know whether it was safe to set sail or whether they would meet a storm. Aviation is keenly concerned with weather forecasting. The military needs weather forecasting for strategic use. It's not until we had forecasting at hand that we identified all of the many ways that it could be useful to us. I think infectious disease forecasting is similar in a lot of ways, the first of which we should be growing into this area and making infectious disease forecasting a key part of the way that we think about outbreak response, both to inform public health decision makers in the same way that cargo ships wanted to be informed of what weather they would face, but also because I think eventually it could be useful to the average person to know whether to bring an umbrella or whether to bring a face mask. It's now becoming more common to produce infectious disease forecasts. CDC helps to coordinate forecasting around seasonal influenza. There's a similar program going on right now around COVID, but I think this is a really important area that we can grow into. The time horizon for forecasting is usually on the order for, I'm probably going to keep saying weather, but I mean infectious diseases, of course. The time horizon for infectious disease forecasting is on the order of 1 to 2 weeks. Any further out than that, and you start to run into problems with human behavior changing what's going to happen. That's one difference that epidemiology has that weather doesn't have. The way that we behave and the choices we make actually change the outcome. And I think that's part of why it's so valuable to give people the tools and the information to make good decisions in their lives, because we want better outcomes than we foresee if things continue on the same course. But it does make it difficult to forecast out over the longer time horizons. And so I think right now around 2 weeks is the sweet spot. Another thing outbreak modeling can do is test various interventions to weigh them against one another. Generally, when you're responding to an outbreak, you're somewhat resource constrained. You can either build more hospital beds or shorten the time to detection, for example. Sometimes you don't have the resources to do both. Or maybe you want to know which one to do first, which one is more important. Modeling and testing, weighing different interventions against one another in modeled scenarios can be really helpful for identifying where the emphasis should be. And I think that can really help us to make better, faster decisions about how to target our resources. I'll note here that experienced epidemiologists and public health decision makers already have a good intuition around these kinds of questions. I'm not trying to say that any of these interventions or any of these approaches to thinking about questions are entirely novel, because they're certainly not. I think what's useful about modeling is being able to really codify and interrogate that intuition, to compare that intuition against modeled scenarios and be able to identify kind of gaps or new ways of thinking about things. I think modeling can really help to structure thinking and bring new light to the way that we think about how we make decisions in public health. I want to return briefly to the 2014 Ebola outbreak to draw out one other lesson learned, and that's that it's not just the fancy analyses that have data. It's also foundational. Let me go back. It's not just the fancy analyses that have value. It's also the foundational data that is really important for making sure that we have at hand what we need to make good decisions. During the 2014 Ebola outbreak, like in many outbreaks, the data flow was not perfect. There were gaps, there were inadequacies in the data that were collected. But there was one challenge that we didn't have that I think is really key for understanding how we should move forward. Each of the 3 affected countries collected the exact same data. That's very uncommon, but the reason they were able to do that is because in advance of the outbreak, there was a case investigation form that enumerated exactly what should be collected: the demographics, the exposure information, the clinical information. That was published and disseminated well in advance of the outbreak. And so when it was needed in the moment, each of the affected jurisdictions had it ready and were able to implement it. Collecting the same data, even across country lines, means that analysts could look and compare across outbreaks, something that's often not possible. And I think that little bit of foresight, that little bit of preparation to develop that form did something really magical and really put us in a better position than we would have been otherwise. And so I think as we look to improving our outbreak analytic capabilities, we also need to put a lot of emphasis on improving the data quality and resolution and timeliness. I think this is critical. Another example of how data can be so useful is around COVID. Evaluating how age trends change over time can reveal how the epidemic itself is changing. Over the summer, it eventually became clear that it was young adults who were getting back out into the community, taking more risky behaviors that came to drive the epidemic or take on a disproportionate burden. More recently, we've seen an increase in school children who are going back to school. But it's hard to make these insights because a lot of places don't publish age trends over time. They publish them cumulatively over the entire course of the outbreak, and so it's difficult to see how things change. I think the fact that it's hard to pick out these trends is an area that we could improve by collecting better data, by publishing better data, and by making it more detailed, more time resolved, more spatially resolved, making it more useful. The way modeling and outbreak analytics works right now is primarily driven through academics. There's a robust community of academics who volunteer their expertise or they receive grants to help support outbreak response and develop the models. It's an incredible wealth of generosity and desire to contribute something to the good that's helping to power the US response to the outbreak. But I don't think we can carry on like that. That's not how we structure strategic national priorities. It's not how we do the weather. It's not how we do the defense industry. For things of strategic national importance, we create dedicated institutions with dedicated funding to make sure the resources are at the ready for when we need them the most. And I think that that is an area that we need to grow into for outbreak analytics. But luckily, I think we are headed in the right direction. On his first full day in office, President Biden announced an intention to create a national center for epidemic forecasting and outbreak analytics, published in National Security Directive 1. And in March, the American Rescue Plan, which is the supplemental funding package passed by Congress, contained $500 million for CDC to implement public health data modernization and to stand up this new forecasting center. I'm really excited to see how this grows, and I think it will be really pivotal to our outbreak response capabilities. I'd like to see this center do three main things. The first is around advancing the research and development around outbreak modeling. Again, leaning on academia to do what they do so well, which is to innovate. It's a pretty small field right now, outbreak modeling, research and development, and I think that there's a lot to grow into. The second major function I would like this center to play is around operations, really taking those research models and making them useful, putting them into practice when there is a crisis, producing the kinds of analyses and insights that we know can be so useful to help support decision making. And the third is around communication, both the public health leaders and the public. Like with weather forecasts, we can use modeled results to help people to understand what decisions to take to protect their health, their communities, and to really get the outbreak under control. In closing, after every crisis, not just in public health, but generally, there's a period of reflection where we assess what we can do better next time. And that's because we know that there will be a next time, and that's true here too. We can expect another outbreak, we can expect another epidemic, another pandemic, and it's excruciatingly clear that it is in our strategic national interest to be ready for that. And I think outbreak forecasting and analytics is key to making sure that we are ready to meet that threat. And I'm excited to see this new Center for Epidemic Forecasting and Outbreak Analytics help to get us there.